Are my slides visible?
Yes, sir.
Thank you. So topic for today's discussion is heart failure, that is HFrEF, definition, scope, and clinical importance. All my esteemed colleagues must be, it is just, you can say, I can't make you more understand. All my colleagues must be very well versed with heart failure with reduced ejection fraction. It is LVF with less than 40%. So that means any patient who's having LVF less than 40%, we can label him as a patient of heart failure with reduced ejection fraction, because as per latest guidelines, 40 to 50% is a moderate type, and more than 50% is preserved ejection fraction. So burden of FRF, it is a lot. It is type of a malignant disease all over the world. If you see the US, there are 6.7 million cases. It contributes to around 45% of cardiovascular deaths, 1.2 million hospitalizations. Lifetime risk is 24%. That means almost every fourth individual will develop heart failure in their lifetime, maybe due to any other reason and any reason. And direct medical cost is quite a lot. That is 32 billion. That was as per 2022 20 establishments guideline on this estimates. So, what are the various causes of you can say heart failure with reduced ejection fraction? So there are a number of causes, but first cause is maybe it is due to heart, you can say MI, myocarditis or toxins which cause myocyte loss and reduced contractility. Reduced contractility is the main cause of heart failure with reduced fraction, because we know that with when the contractility reduces, the ejection fraction reduces, and the patient goes into HFrEF. We know all the symptoms of the HFrEF, that patient is having shortness of breath, there is pupil edema, there is decreased appetite, PND is PND is there, orthopnea is there. There is chamber dilatation, wall thinning, increased LV volumes that can be seen on echocardiography, and worsening systolic performance. So then there comes neurohormonal activation and hemodynamic consequences, which lead on to reduced cardiac output, elevated filling pressures, congestions, and progressive symptoms, which I have already told you. So then come, what are the various causes? One is, first is ischemic and structural, which we see day in day out. Ischemic causes are seen all over the world, but valvular heart disease may be rheumatic. That is seen usually in Indian subcontinent. Non-ischemic, it can be dilated cardiomyopathy, which can be idiopathic or genetic. It can be cardiac amyloidosis, sarcoidosis, or hemochromatosis. And toxic chemotherapy cardiotoxicity. It is a major cause and right now in number of patients who are receiving chemotherapy. So we should be very cautious about patients who are taking chemotherapy. So to see their echocardiography after every 2 or 3 chemo visits, so that we can just save them from getting heart failure. Because this is, I must say that this is the only heart failure which is preventable. All heart failures are due to some other cause, but this is due to toxins of chemotherapy. If we work good on these patients, we could do echocardiography with the help of GLS. We can avoid this type of cardiotoxicity and you can say heart failure. Then it can be tachycardia mediated cardiomyopathy, which can be due to AF or frequent PVCs, thyroid disease, or peripartum cardiomyopathy. I have seen a number of patients where peripartum cardiomyopathy is also to be seen, and we have to keep our eyes open. If the patient is having, you can say, tachycardia, shortness of breath, it is always not due to the pregnancy and its effects. It can be due to cardiomyopathy. So, recognizing HFrEF, what are the symptoms? Congestion, typical symptoms, exertional dyspnea, orthopnea, PND, fatigue, decreased exercise tolerance, exam signs, elevated GP, pulmonary crackles, and peripheral edema is there. Exam signs, a hypotension can be there if that is a low output heart failure. Cool extremities and narrow pulse pressure. Red flags, what are the urgent action, you can say, problems? One is hypotension. acute pulmonary edema, cardiogenic shock, syncope, rapid weight gain. We have to see that the patients of heart failure, they don't gain weight. Once the patient starts gaining weight, that means patient is decompensating. Acute versus chronic, acute decompensation often presents with pulmonary edema. Chronic HFrEF, it is progressive exercise intolerance. So if we get a patient of HFrEF with us, we have to see what are the symptoms, how we can avoid, how we can treat them, and how we can diagnose them, and how progressively we have to see, because heart failure with reduced ejection fraction is a malignant disease. It keeps on waxing and waning. It keeps on increasing. We have to see that we just allay the symptoms and signs and of the patient, and also try to increase his EF so that he doesn't fall back again and again into FRF. Diagnosing initial test is ECG, chest X-ray, and anti-pro-BNP, which is point of care test. In my OPD, all my patients who are coming with shortness of breath, they always have to undergo anti-pro-BNP. And I have seen a lot of patients where we can't differentiate between whether the patient is a cardiac patient or the patient's shortness of breath is due to anemia or due to pulmonary cause. Anti-proBNP gives us a very good and very fair reading that whether the patient is due to HFrEF. We have to see the CBC, electrolytes, renal profile, TSH, iron studies. Iron studies we have to see in all HFrEF patients, because anemia and this decreased iron levels, decreased ferritin levels, they contribute a lot to the this patient symptoms. Confirmatory imaging is transthoracic echo to measure LVF, chamber size, valvular disease, and HFrEF. HFrEF is standard level 40%. We also can do the patient's GLS and other systolic imaging patterns. Advanced imaging, cardiac MRI can be used if amyloid is suspected, but amyloid should always be suspected if we have a GLS pattern of apical sparing. Functional assessment like 6-minute walk test or exercise echo. I don't think any much of the patients will be able to do exercise echo. Then coming the severity, there are two different type of guidelines. ACHI stages. A is at risk. B is pre-heart failure. Structural disease is there, but no symptoms. That means EF is around 40 to 50%. There are no symptoms. Third is symptomatic heart failure, and fourth is D is advanced heart failure. If we go by the classification, NYH is no symptoms, is class 1. Class 2 is mild limitation. Class 3 is marked limitation. And fourth is symptom at rest. We should try that the patient should always fall back to class 1 or class 2 from class 4 or 3. So that with the help of newer GDMT drugs and other modalities, we can make it happen. Therapeutic principles, how to stabilize HFrEF. First is stabilize. We have to stabilize the patient of HFrEF with, we have to treat hypertension if the patient is into hypertension. But lot number of patients come with tachycardia. We first have to, you can say, stabilize the tachycardia if the patient's heart rate is to the tune of around 50 to 60, which is the target range for any HFrEF patient. A lot number of patients will get stabilized. So with the help of beta blockers, and if the heart rate is more than 70, even with beta blockers, we can start with ivabradine to decrease heart rate to the tune of 50 to 60. But if arrhythmia is there, we should not go for ivabradine. Then decongest, you use loop diuretics. Because if we have to see that the patient's anti-proPNP is more than increased quite a lot, like to the tune of 15,000, 20,000, we have to offer him loop diuretics in the form of IV loop diuretics, so that patients can be decongested. Loop diuretics, they are not a part of GDMT, but they are the first drug to decongest the symptom. Once the patient's anti-proBNP falls back to normal, that means around 1000 or so, that patient, we can label the patient as chronic HFrEF. We should avoid loop diuretics, so that this part of BP, which is decreased by loop diuretics, can be given to accommodate the dosage of ARNI and other drugs which decrease the BP. Then initiate GDMT. We have to start GDMT as early as possible. Earlier evidence was this, that it should be started in a sequential manner. But right now the data says that we have to start it as early as possible with all the 4 drugs together, maybe in the minimal dose, and we can escalate the doses of all the GDMP drugs. Then modified disease, we have to consider device therapy, revascularization, and targeted treatments wherever indicated as per the etiology of the HFrEF. So non-pharmacological foundations for HFrEF, we have to see diet and fluids, there are sodium restrictions, individual fluid guidance. I always ask my patient to restrict his fluid levels to the tune of around 1 liter, 750 ml to 1 liter per day. Daily weight monitoring should be there. Activity should encourage regular activity and cardiac rehab as early as possible to improve functional capacity and quality of life. Smoking session has to be a part and parcel of all the patients who are going HFrEF treatment. Alcohol should be avoided. Plays a big part. If the patient is obese, we have to see that the patient is whether suffering from obstructive sleep apnea or not. If the patient is suffering from obstructive sleep apnea, we see that the patient is snoring a lot, we have to calculate Epworthy sleepiness score. If that is more than 10 or 15, we should go for a sleep study and give a CPAP or BiPAP to the patient as per the optimization of for the sleep study. If the patient is having a substance use, we should ask him to avoid this substance as soon as possible. We can have vaccination, influenza and pneumococcal vaccination. These are recommended. Pneumococcal is to be given once in a lifetime, influenza for every year. We have to manage comorbidities, hypertension, diabetes, CKD, hypertension. Our goal should be, BP goal should be around 120 by 80, which is as per the latest guidelines, 124 by 80 as per the latest guideline. Diabetes is HbA1c level should always be around 6.5, not more than that. We also should see that when we are giving GDMT with SGLT2 inhibitors and other drugs, patient is not falling into hypoglycemia because hypoglycemia is more dangerous as compared to hyperglycemia. CKD, we have to see the patient's renal parameters are within normal limits. But if the patient is suffering from CKD, we have to limit the usage of ARNI and eplerenone, this MRAs, because MRAs they tend to do hyperkalemia and also the ARNI, but they should be given as far as possible and as the patient tolerates in the maximum dose. But right now we have seen that a fifth pillar of drug has come, that is vericiguat. If the patient is having worsening heart failure is if the patient has a history of IV use of diuretics in the last 3 months or admission due to heart failure with reduced ejection fraction in the last 6 months. That is the patient of worsening heart failure. In these patients, we should start with vericiguat as soon as possible so that this is now right now called the fifth pillar of the HFrEF management. Self-management patient can be advised for education on meds. Clear symptom action plan should be given to them and also asked to monitor his activities and monitor his weight, BP, and pulse rate. This is the same four pillars of HFrEF. First is ARNI, ACE inhibitors or ARBs. The first drug of choice is now right now ARNI. Second is MRA, which can be spironolactone or eplerenone. Neurohormone modulation can be done with beta blockers, but if the patient size heart rate is more than 70 in spite of beta blockers, we can go for ivabradine also. But if the patient's BP is less, we should give beta blockers. We should give ivabradine so that the patient's heart rate is to be kept between 50 and 60. If we keep if the heart rate of the patient of this HFrEF is kept at around 50 to 60, it will be we will be allaying the symptoms of heart failure as very early. Acid inhibitors, they are a part and parcel of GDMT to reduce mortality and hospitalization. So coming to initiation and titration, we should start low dose therapies, but they should be started as early as possible. We should monitor labs, like I told you, we should check the BP and heart rate. Heart rate has to be again and again. I'm saying that heart rate is get at between 60 and 70. Potassium has to be seen to monitor the dosage of eplerenone and ARNI. Diuretics should be avoided as far as possible if the patient's anti-BNP is more than 1,000 or something like that, or the patient is exacerbating. We can use loop diuretics, but they don't give us any benefit of mortality and morbidity in these type of patients. Up titration should be done as soon as possible, but slowly. And we have to see that intolerance also, whether the patient is going into hyperkalemia or hypotension like that. So adjunct pharmacological options, diuretics only to be given only to relieve the congestion. Hydralazine isosorbate nitrile can be given in select patients which have persistent symptoms despite GDMT. But right now I say that vericiguat is our fifth pillar. Evaporatin, sinus rhythm more than 70 in spite of beta blocker, as I told you. Iron therapy has to be given in all heart failure patients. We have to see that patient is suffering from this iron deficiency or not. We can go for iron studies, and 90 to 95% of patients, they suffer from decreased ferritin levels in the blood. But some data, new data says that even if we get a patient of HFrEF, which is admitted for HFrEF, that means worsening heart failure is there or acute decongestion is there, we have to infuse him with ferric carboxymaltose. Anticoagulation should be done if the patient is having AF, but it is not for HFrEF routine. What are the devices that can be used in HFrEF? One is ICD or CRT. ICD is to be used if the AEF is less than 35%, uh, despite more than 3 months GDMT and life expectancy is more than 1 year. But CRT is to be used if LVF is less than 35%, but QRS more than 150 with LVP. In these type of patients, CRT should be used. Advanced therapies, we should have identified refractory HF, referral triggers if they are there, like refractory arrhythmias or intolerance to GDMT. We should go through them. If the patient is having refractory arrhythmias, we should go for Holter monitoring to see that what kind of treatment should be given. Maybe some patient is needing Omidron and multidisciplinary evaluation. We should, if the patient is, you can say, willing, we can advise them LVAD in if the patient is not improving in spite of medical therapy. AF, chronic kidney disease, we know we have to treat it as per the patient's profile. AF should be treated with Omidron, and anticoagulation should be given as per Chadwell score. AF ablation should be considered, but it has not got very good results. Maybe patient has to go AF ablation for at least 2 to 3 times for proper AF ablation. CKD should be monitored. SGLT inhibitors should be given as per the patient's kidney profile. Diabetes patients HbA1c should always be kept around 6.5 or so. There should not be any peaks and troughs. Patient should not be having multiple episodes of hypoglycemia. If need, we can ask the patient to undergo CGM also. Assess iron studies, we can give iron therapy whenever needed. So we should look to it that the patient is not readmitted for heart failure in next 30 days, which is the case. Usually around 40 to 50% of patients, they come back to us with heart failure admission in next 30 days. There are some corrections of myths that stop beta blocker. If EF is low, we should be beta blocker should be given at any you can say place in heart failure. Have to keep heart rate between 60 and 50 and 60. ARNI and ACE inhibitors, they are not interchangeable. ARNI has got better results as compared to ACE inhibitors. We have seen the paradigm HF trials. Diuretics worsen outcomes correction. This is a myth that diuretics worsen outcomes, but they relieve congestion, they improve quality of life, but they should be taken off the treatment once the patient is euvolemic. And SGLT inhibitors, they are not only for diabetes, they are part and parcel of our treatment. These are simple cases. I think we should go for it. These are evolving evidence of emerging therapies. Therapy evolution is quadruple therapy. If you have to GDMTs, RNA, beta blocker, MRA, agent inhibitors, they should be given in all patients. Now the trials suggest that additional agents like vericiguat may provide incremental benefit. Enhanced phenotyping enables disease-specific targeted therapies and early diagnosis. These are precision approaches which are under consideration till now. Implementation gaps, less than 25% patients receive quadruple therapy. We being EECP physicians, we being you can say where we can get a lot of heart failure patients who can come to us that we are not getting our symptoms controlled, we are not getting our EF improved. first and foremost thing is we should see that the patient is receiving GDMT. Only then we should start with other modalities. So, what are the key takeaways? Screen and diagnose. We should see that the patient is having EF less than 40% on echocardiography. If there is GLS finding on that, it will be an you can say icing on the cake. We can see the how much is the damage to the cardiomyocytes. Anti-proBNP should always be taken to, so that we have to see that patient is not having acute episode, because if we want to start any therapy, the patient should be chronic heart failure patient. It should not be into acute heart failure. Initiate quadruple GDMT. Early follow-up self-management should be done, and refer appropriate to the patient needs ICD or CRT after GDMT optimization. We would start with that. So this was, you can say, just initiation about the heart failure of a patient that come to us day in day out. How we can stabilize them? If the patient's anti-proBNP is higher, we should start with the loop diuretics. GDMT should be given as early as possible. If the patient is having history of worsening heart failure, vericiguat should be given as a part and parcel of pentavalent therapy.
Are we done, Dr. Singla?
So let's make few slides more.
Okay, no problem. Take your time. Sorry. Very interesting thus far. Thank you.
Welcome, sir. Now coming to the topic for EECP for heart failure. Now this is clinical introduction. We have gone at that already. We have seen that how to manage for how to diagnose, how to manage heart failure with GDMT, and once the patient is euvolemic, the patient is out of acute episode, then we can consider EECP for these type of patients. This is already we have gone clinical impact marker where ECP symptoms can be given. So one thing is that we all know that we all are ECP physicians. We can give ECP to the patient. First thing is that we should always see that the patient is out of acute congestive episode. We have seen that patient setup can be done. Sequential inflation is there. We all know it day in day out. Typical regime is 35 hours. So what are the hemodynamic mechanism of EECP? First thing is diastolic augmentation. Sequential cuff inflation generates retrograde pulse waves, raising diastolic aortic pressure and coronary perfusion. So now this diastolic augmentation, it can be used in patients with HFpEF, but the data is still not there. But whether we can use EECP in patients of heart failure with preserved ejection fraction. Heart failure with preserved ejection fraction is where the heart EF of the patient is more than 50%. The patient is having on echocardiography E is less than A, so that means there is atrial relaxation is not proper, which is part and parcel of some diabetic and hypertensive patients. Some data says that around 70% of diabetic and hypertensive patients, they are walking heart HFpEF patients. But whether ECP can be used in this type of patients, it can be used if we say that theoretically it can be used, but I don't think there is any data. Dr. Mohan can enlighten us later on. Increased venous return, lower limb compression boosts preload and central blood volume, potentially improving cardiac output. Then another is afterload reduction, rapid cuff deflation at systole. It lowers systemic vascular resistance, decreasing myocardial workload. Again, increased EF. Net cardiac effect is enhanced coronary oxygen supply plus reduced workload. It can improve systolic systolic and diastolic function and exercise capacity. If we are improving diastolic function, theoretically, again, I am saying that it can be used in health for patients. How EECP improves endothelial function? Endothelial shear stress and function. Increase pulsatile shear during EECP upregulates nitric oxide pathways. Nitric oxide, we know, it helps in vasodilatation and microvascular perfusion. Then collateral recruitment angiogenesis. Repeated diastolic augmentation promotes collateral flow to ischemic myocardium. Once we increase the collateral flow to ischemic myocardium, the cardiomyocytes which are hibernating, they can come back to normal function. Clinical reports note lasting symptomatic improvement up to 2 years. Peripheral circulation changes are there. Enhanced lymph perfusion may reduce peripheral symptoms and it improves exercise tolerance in heart failure patients. Whenever we are giving ECP or any type of treatment to the patient, we should note that the patient's symptoms are reduced. We should ask the patient for simple tests. We can ask the patient to undergo a 6-minute walk distance. This will give us a fair value that whatever treatment we are giving to the patient is improving or not. See, the EF will improve in a quite lot of time. That may be around 3 months, 5 months, 6 months, right? Only two things that can be demonstrated easy to the patient is one is anti-proBNP levels, which are decreased very easily with the help of GDMT and you can say this loop diuretics. But 6 minute in ECP, we can ask the patient to undergo a 6-minute walk distance, 6-minute walk test. If the 6-minute walk test patient improves his distance that he cover improves, we can ask him that we can tell him that see our treatment is giving you a good improvement. Patient selection, we have to see the symptomatic only patients class 2 to 4, but ideally only 2 to 3, 4. I don't think should be given because they are decongested patients on optimal medical therapy. Disabling stable angina, which is not amenable to revascularization, this can be used. High surgical risk patients, the patients who can't undergo CABG or who have unsuitable coronary anatomy, the patients who are having microvascular angina, they can also be taken up for ECP. Contraindication is hypertrophic cardiomyopathy, significant valvular disease, and large heart. Large heart, not to the tune of like if we are seeing the patients of ischemic cardiomyopathy, where the you can say the heart size is LV size during diastole is around 55 to 60 that can be used. But if the patient's heart is quite enlarged, like in patients of DCMP, where it is genetic, it can be a contraindication. Atrial fibrillation, pacemaker dependence, and uncontrolled hypertension, they are contraindications. Peripheral artery disease, active DVT, bleeding disorders, aortic aneurysm, and aortic regurgitation. Standard protocol is 35 1-hour sessions over 7 weeks. Alternative dose 15 to 35 hours. It can be used. Symptomatic response may occur with shorter courses for some patients. Drug therapy, we should always monitor drug therapy. ECG circulation has to be seen at every outset. Whenever the patient comes to us, we should always see his blood pressure and heart rate before starting the EECP. We have to see the assess patient's limb ischemia or discomfort. And in some cases, if the if the patient permits, we can take stress test pre and post for the patient. Like we have a lot of heart failure patients, so I think 6-minute walk distance can be a very good indicator for these type of patients. So clinical evidence, we have to see the symptomatic relief, function, and quality of life. Because at the end of day, we have to see that the patient's symptom is reduced, his quality of life is increased, and he can get a better functional capacity. So that means there can be reduced angina frequency, increased exercise duration, decreased nitroglycerin use, effects duration up to 2 years. Heart failure studies like cohort and trials, they assess systolic diastolic function, ergometric power over 1 year. ECP is associated with reduced angina, improved exercise ECG duration, and patient reported energy. So I have 4 or 5 patients who had undergone ECP for heart failure. Like I had a patient of LBB who outrightly rejected that he won't be able to undergo on this angiography. So when I admitted her, around 1.5 year back, her EF was around 33-34%. Her anti-proBNP level was to the tune of around 15 to 20,000. She had come to me in an acute decompensated state. I admitted her, started with GDMT and IV continuous infusion doses of this loop diuretics. Once the patient's anti-proBNP level came around 5,000, I discharged her on the same treatment with GDMT and oral diuretics. Once the patient's anti-proBNP level came back to around 2,000, that means patient had gone into from acute HFrEF to chronic HFrEF. Right. Then I started the ECP of the patient. She had undergone around 35 sittings. And ultimately, I didn't do her echo at the end of EECP, but after 3 months of stopping her EECP, and her EF at that point of time was around 50 to 55%. Patient was off diuretics. She was plainly on GDMT, and her symptoms, they were absolutely fine. I have seen this patient for another last 6 to 8 months, and again this echocardiography was done. Her GLS has also improved, and her EF is almost stable. ECP, we all know that mechanism. We all know the mechanisms. Benefits are non-invasive. Only limitation that comes to us is time intensive. Patient has to come once a day for 35 days. This is a big hope. Safety profile, we have to see leg discomfort. Monitoring has to be seen. His BP, ECG has to be seen. His DVT has to be taken care of. Contraindication is screened to AF, valvular disease, recent stroke or MI. Now, coming to these things, ischemic, that where in which areas can we give ECP? Ischemic EF, heart failure, it is beneficial, no doubt about that. Non-ischemic heart failure, it can be beneficial, may relieve symptoms, but evidence is there, data is less robust as compared to the ischemic heart failure. Heart failure with preservation fraction, as I told, evidence, it is data is emerging. Theoretically, we can give because this improves diastolic augmentation. But data is still not so much data is there that we can give it to guidelines. So, how to integrate with guideline directed medical therapy? First is identify candidates, pre-treatment assessment, referral. We should stress test, contraindication should be screened out, informed consent should be there. But I will always say that the patient has to undergo a GDMT before starting ECP, and the patient's anti-proBNP should be around 1,000, not more than that. The patient ideally should not be on loop diuretics, but wherever needed, it should be given. These we know that operational needs and all that. Patient NYHA classification post ECP, usually it improves, exercise capacity is increased, medication use, sublingual nitroglycerin frequent is decreased if the patient we are doing for refractory angina, and quality of life is improved with ECP in these type of patients. Key takeaways: it is a safe, non-invasive option to improve perfusion. Referral selection should be done very, very diligently. Implementation, we should start with GDMT, and we should keep on researching and monitoring for these type of patients. Thank you so much.
Thank you so much, sir. Sir, I sent you some question on your WhatsApp.
Yeah. Yeah. Should we avoid ECP in patient with severe LV dysfunction? If the patient is quite, Dr. Mohan, what is your opinion about it? I'll just have your opinion first, then I.
Yeah, Dr. Rakesh.
Dr. Anupam can guide us in
Sorry,
this.
sorry, Doctor. What is your question again?
Sir, should we avoid ECP in patients with severe LV dysfunction, EF less than 25%?
The problem with EF is that, is this on? The problem with EF alone is that it's not very accurate when you're using echo itself. Remember, echo takes an average of 8 beats and calculates the ejection fraction. And if the patient has arrhythmias, it will not give you an accurate response. Whereas we use three-dimensional vasculography, which takes 90 beats or more and calculates the ejection fraction. Remember, what we do is we exclude the part where there's arrhythmias. And with these patients, for example, if you get a premature ventricular contraction, the heart rate would increase, and then it'll take time for the heart rate to stabilize. How? Because you get a block, and then we come back to a normal rhythm. So in that phase, we exclude the highest beats, the highest readings, and the lowest readings, and we calculate the average based on that. So that's why I say that the echo itself is not a very, how should I say, accurate assumption of how the patient is doing in patients with arrhythmia. It just depends on the type of patients we're doing. So if you had to, as you say, associate it clinically with the patient, if the patient can walk and do everything, and you say they have an ejection fraction of 17% or 15%, that makes no sense. So we have to look at that more critically before we accept the ejection fraction as a parameter to define whether we should do ECP or not.
So my take is that we should not only we should consider not only on EF, because EF is a two-dimensional, you can say, parameter. If we are having other parameters of systolic function, like I am in my echoes, I always give LVOT diameter, LVOT parameters, then his other parameters, global EF. So I think if the patient is stable, we should offer him EECP.
Dr. Singla, myocardial viability is the key factor in this.
Right, sir.
Before taking a patient, you must watch myocardial viability and how much myocardium is working properly. That is the key factor in improvement and prognosis.
Right, sir.
Very well elaborated, very good talk, very informative talk. I must congratulate you and ICPA, Dr. Sanoj and Dr. Rakesh Mohanlal to organize this wonderful webinar.
Thank you so much, sir. Thank you for the nice words.
Thank you, sir.
Well elaborated.
So next question was, what clinical improvements can we expect in HFrEF versus HFrEF patients after ECP? See, in HFrEF, I have already told you that the data is robust, that HFrEF after ischemic episodes, it improves a lot. But in HFrEF patients, it theoretically can improve, but we don't have much of data. Ideally, we all should try to do research in this, that we all start doing some patients of HFrEF on ECP. It can be on experimental basis. Dr. Sanoj can correlate on, Sanoj can do something, medical protocol, that we can come out with some trial where we can see that what is the effect of ECP on FF patients. Dr. Rakesh, can you guide us in this?
Yeah, that's a good idea. And obviously, at any time where we see we collaborate our efforts, we'll get a good response and publish the data.
It's
I think
like
establish Dr. Singla and the rest of the listeners or participants is that we need to establish a proper clinical pathway for ECP. Where does it come in? Where does it? Because that's a part that's lacking, I see, when it comes to the practical part of ECP. Because the clinical pathway is not properly defined. It's defined by old rules and old systems. And I think it's time that we readdress that to find a proper clinical pathway and then institute guidelines in order to carry that forward for whoever is doing ECP as ECP practitioners. I think that's one of the important things. If you don't mind, the other few things that I wrote down was the ICD. We found that in South Africa, when we looked at it in every different hospitals, when I was moderating the masters and BTech students' theses, and they were working with cardiologists who were doing the implants. Every presentation that was done, you wouldn't believe that it had very poor outcomes with the ICD. So I don't know if that is a good idea, because putting them in patients sometimes with heart failure makes no sense. The arrhythmias itself on ECP, I found that more than 95% of the patients, the arrhythmia sort itself out with ECP. As soon as you perfuse the heart, remember what we found is that if you do three-dimensional vasculography, you find that there's a problem normally with the SA node not getting sufficient blood supply from the sinoatrial artery. That's one of the reasons why they have ectopic beats or arrhythmias. The second thing is that there is decrease in blood flow in the LAD territory, in the midsection of the LAD. So when you find the anterior part of the heart is not getting sufficient blood supply, because the conduction system becomes impaired after that. So what happens is when the SA node fires and comes to the AV node, there's a delay in the time signal from the time it reaches the AV node till the time it reaches the bundle of His and the Purkinje fibers. So that time delay actually causes extra waveforms, which is like premature ventricular contractions. And that's why we find arrhythmias in this patient. So once you perfuse the heart and the LAD territory in that region gets good blood flow and the SA node gets the blood flow that it requires, we find that the arrhythmia sort itself out.
Yes, sir.
Sorry,
No doubt about that.
You know, these are the things we found. Also, vasodilation with nitrates is not always the answer, because what we found, again, using three-dimensional vasculography, is that with a lot of patients, almost 35 to 40% of our patients are vasospastic. That means when you give them nitrates, they go into spasm. And these patients, we find that the pulmonary vascular resistance drop, the airflow to the lungs increase, but the coronary arteries go into spasm, and we actually see a decrease in blood flow to the myocardium. But we find that the oxygen concentration to the heart actually increases because the lungs improve. So it's a catch-22 situation with nitrates. So my advice is, going forward, if you see the patient is on nitrates and not doing well, if you don't have a three-dimensional vasculography machine to assess that, stop the nitrates for a while and you'll see a difference in the patients. Also, another thing that I must add, just realize it, is pro-BNP. For heart failure, this is, for us, that's one of the most important parameters that we look at. We do the pro-BNP before and after ECP, and you'll see a vast difference. Patients come in with pro-BNPs of 17,000, 15,000, 13,000, and we see them coming back to 600, 500, depending on the age profile. So I hope that's helpful. Thank you.
Yes, sir. I've seen some patients, if we are giving them good GDMT and ECP, the patients come back into around normal type of anti-proBNP levels. So next question was, is there any evidence showing improvement in EF or only functional improvement? No doubt there is EF is improved if the patient is having ischemic cardiomyopathy, ischemic half ref. And so next was, EECP safe for patients with severe MR AR. The patient can be given for MR but not for AR. AR is the strongest contraindication for EECP. How do you manage patients with borderline BP or hypertension during ECP? If the patient is going on hypertension, we have to see whether this patient is perfused or not. We can ask an echocardiography to see if the patient's IVC is collapsed or not. If the patient's IVC collapsed, that means patient is having hypovolemia. We can just jack up his oral intake. What precautions should we take? Yes, sir.
Can I add quickly to your
Sure, sir. Please.
God. Okay, go on. I'll come back to you.
No, sir, please carry on. I'll just.
What was the first question? Oh, the blood pressure. Yeah. So what we find with patients with heart failure is that the blood pressure is normal. That's one of the assets or one of the advantages of heart failure. This is the body's way of creating hemostasis. Because what happens is, literally, the heart fails, that decreases your blood pressure, and the blood pressure on the heart then decreases. So the patient is able to function. They will not perform well, but they will be able to live. So what we find that with heart failure patients, generally the pressure is normal if they are in heart failure. If they're heading towards heart failure, then their pressure is high. You see, if the pressure is high and the blood pressure and the heart rate is high, that means the patient is going into failure. So generally what would happen in heart failure is that the blood pressure would normalize, and sometimes the patient's heart rate will be high. And eventually, when the EF is very low, the heart rate is slightly high and the blood pressure is normal. They don't even need vasodilatory drugs, you'll notice at that time. So if you're doing patients with serious heart failure, you'll notice the BP is always normal.
Right, sir. Thank you for your nice explanations.
What was the second thing you spoke about just now, sir?
So that was the only thing, sir. EECP safe for patients with severe MR or severe AR.
Yeah, that's a good one, because that's always a very controversial topic. And what we see there is that with patients with AR, so trivial AR, mild to moderate AR, we treat the patient. And some patients who are moderate AR, but moderate to severe and severe AR, we don't treat. Now, this is from my experience in South Africa, and even currently we're treating people with that, and we've just completed some of them. And they have fantastic results still. It's actually such a nice idea to do an echo on these patients pre and post. Because remember, when the patient goes into heart failure, there's physiological changes that occur in the patient. And once you re-establish the physiological parameters in the patient, we find that you'll be shocked that we found patients with mitral regurgitation from moderate, it came back to trivial. And from AR, from moderate AR to mild AR. So you can't have, I don't think drawing a blanket this thing over that makes sense, because we've done enough patients, so we've done that. You know, these patients, people can say that it's not possible, but they haven't done it, and we have done it. So if you climb Mount Everest, then you'll know what I'm talking about. Reading the book about climbing Mount Everest is not the same as the person who's done it. So from our experience here, trivial, mild to moderate, and moderate we've done. We don't take moderate to significant, and we don't take severe, basically.
Once the patient's EF improves, once the patient's coronary perfusion is improved, these, I think, valvular lesions also come back to, you can say, from moderate to trivial type of the patient that I was talking about. When I started the ECP, MR was around moderate only. But once I finished it came back to around trivial or something like that.
Yeah, that's true. So it's good that you're doing echoes before and after, because that's one of the ways to judge.
It makes you wiser, sir.
It's true. This is such an interesting topic. I wish more people could have been here, but I think we advertised this late. But I'm still getting glad we did it.
Next question was, sir, what measurable improvement should we expect? EF, obviously, EF is improved in ischemic heart failure. Symptoms, patient improves symptoms. 6-minute walk test is always improved. Anti-BNP and Dr. Mohan also told that BNP improves. And overall quality of life, if we see the symptomatic life, his quality of life is improved. How long do the benefits last? The benefits, we know that it can last up to 2 to 3 years. I have started doing ECP on for the last just 2.5 years. I'll ask Dr. Mohan to please elaborate on this.
So our first patients that we did with the EF of 17, EF of 20, 25, our oldest patients so far lasted 15 years. So I know that the Americans did publications where it was first 2 years, then 5 years, then a 7-year. But so far we've done our longest patients with 15 years, and we have quite a few of them. But generally we see the patients come back after 7 years, 9 years. That's the time period. And remember, the difference is like with most other people who do ECP, they do 35 treatments and wait for the patient to come back if they are symptomatic, whereas we do follow-up. So we do a maintenance program. After we've done the 35 sessions, we do 24 sessions a year. So the patient comes in every second week for 1 session. And in that way, we've seen patients here for 8 years, 10 years, completely asymptomatic. So there's hundreds of ECP.
Yeah, if we keep the patient on good follow-up and keep on following him with all GDMT and all that, I think the EF once sustained can be sustained lifelong.
That's true, sir, because at the end of the day, there's a lot of changes that occur in the patient as you progress with ECP. And 35 days may not be adequate to reverse all the damages that's occurred in the patient. So when we're doing the follow-up during the course of the year, whatever we could not achieve during the 35 days, we do during that part of the treatments. And the patients are very impressed and very happy with this. And that is how come they continue every year. In this way, you have a good rapport with the patients, you have good feedback, you know what's happening. And also, they're not going to multiple other practitioners and changing their treatment regimens and changing the medication and having problems and coming back to you.
Thank you so much, sir.
Thank you, Dr.
I think we can call it a day. Dr. Sanoj?
I think Dr. Sanoj asked me to just say thank you to all of you. I want to say that again, Dr. Singla, thank you for taking your time. We know that you were not well recently. We hope you're 100% better now, and God bless you.
Thank you so much for the wishes, sir.
And for the participants who joined, I really thank you from the bottom of my heart for taking that time, and we appreciate it. As I say, the funds that we collected will obviously go to the website, and you'll see the benefits of being in that website and what it will do for the IECP and all practitioners in the future. I want to say thanks to Dr. Sanoj as well to put this together, Mr. Suri for sponsoring part of this and being part of it from the beginning to get this webinar sorted, and our president, Dr. Sibia, our vice president, Dr. Srivastav and Dr. Rufman, and all the participants for taking the time to make this possible. And to the IT team, thank you very much. We really appreciate it. If Dr. Sibia can possibly say a few words, because I couldn't get him on the phone, I will appreciate it. Thank you again, Dr. Singla. Dr. Sibia, if you can say a few words and we'll end there. Thank you. I think Dr. Sibia is not on the thing, but again, I want to say thank you. We're going to try and have these webinars more often. Please, whoever is here, try and encourage the rest of your colleagues and partners to join, and also give us the topics that you want to discuss. And we encourage anybody in this group here to present whatever you know, whatever you think. You know, we don't have to. You don't have to have 20 years experience to do this, because we are sharing knowledge here. So
Obviously,
whoever can come forward in the group and say, I'd like to present on a certain thing, you present, share your knowledge, whatever little or lot you know, and other people can also give their comments, and then we share as a team and improve as a international society.
Yes, we all should remain a student whole of life. You should keep on learning.
Always. Thank you,
Right.
Dr. Singla.
So I'll just make it a point that we should make some guidelines for this. I think we should work earnestly for making some guidelines.
I totally agree with that. I think there's enough people in the International ECP Association to be able to put that together. So one person doesn't need to do everything, you know. So if each of us takes a small section and we take the sections and agree to work on it individually and then put the book together, it'll benefit us and everybody else.
We should do this, sir. Because we just last week we unveiled guidelines for Indian Hypertension Society. I was a part of that group, and I just made guidelines for hypertension and obesity. So if we can just
have some experience already, sir. So you can help us.
If you can give some topics to each and every person who is actively involved in doing an ECP, we can make sometimes maybe in next you can say have Congress or international Congress, we can come out. We should come out with some guidelines.
We'll do that, sir. So what we'll do is we'll try and put people together and put some names together and some topics, and then we can draw it, and you can help us and guide us, since you've already done that.
Sure, sir.
Thank you, Dr. Singla.
Right.
Thank you to everybody.
Good night, sir. Good night, sir.
Thank you. Good night.
Right.
Pulse ECP therapy system, a breakthrough in external counterpulsation. Heart health is life's greatest treasure. At Genesis Meditech, we bring you the future of non-invasive cardiac care. Pulse ECP, the future of non-invasive cardiac therapy. The only system in the world offering an unmatched 10-year warranty on compressor, motherboard, and software, along with 1-year full warranty of the system. AI-powered therapy. JECPOS. AI algorithm automatically manages inflation time, pressure hold, and deflation time. Unlike the conventional systems, VarioPulse uses high-speed microcontroller technology, ensuring precise ECG synchronization, faster processing, and reliable treatment every time. Engineered for patient comfort and doctor convenience with ergonomic design and intuitive controls. Clinically proven to improve cardiac function, enhance blood flow, and transform patient quality of life. Trusted and recommended by leading cardiologists across India and beyond. Introducing the VarioPulse ECP therapy system, a breakthrough in external counterpulsation, designed and manufactured by Genesis Meditech Corporation. Proudly made in India with world-class standards, VarioPulse is already making a global impact. VarioPulse ECP, the smarter, safer, and effective ECP therapy system